Hello and welcome to this Nature Research custom media webcast titled Novel Data Collection Strategies for Today's Infectious Disease Research, Transforming Infectious Disease Research through Implementation of Digital Methods, Wearables, and Social Determinants of Health Data for Early Detection. My name is Sarah Hiddleston and I will be your moderator. Today's webcast is sponsored by Vibrant Health. The arrival of COVID accelerated significant innovation in digital technologies for remote and virtual methods for clinical research and care delivery. This webcast will explore opportunities for acquiring and utilizing data from new sources, such as wearable devices and mobile phones. It will address ways to overcome obstacles to accessing such data, the realities of combining these data with other data sets, data security and privacy-preserving approaches. With us in the studio today, we have three speakers. They are Dr. Omer T. Enan, Professor, Linda J. and Mark C. Smith Chair at Georgia Tech College of Engineering, whose focus is developing technologies for home to monitor chronic diseases, including heart failure. We also have Dr. Denis Nash, Distinguished Professor and Executive Director, CUNY Institute for Implementation Science in Population Health, whose expertise is in infectious disease epidemiology. And finally, we have Pradyuman Jain, Principal Investigator, Participant Technology Systems Center, United States National Institute of Health All of Us Research Program, who is the CEO and founder of Vibrant Health. We'll then move on to a question and answer session with you, the audience. You can ask a question at any point you wish throughout the webcast. To do so, please type your question in where it says type your questions here, and then press submit, and we will answer them at the end of the session today. And now, over to our speakers.
Hello, everybody. Thank you, Sarah, for this introduction. Today, we will be talking about how, as infectious disease research community, we protect our society. How do we take proactive steps and move left in early detection through a central theme of data? And how do we utilize data to become more responsive as infectious diseases come and go? These are the speakers for today that Sarah has introduced. As researchers, we always want to be thinking about how do we get ahead before the next crisis comes. These are some of the areas that the research community has been working on through smart testing approaches, which we have heard a lot in the last 3 years. We have heard less about comprehensive data collection. That's one area we want to be focusing on. We also want to talk about precision detection and monitoring. What's the role of genomics and AI and local prevalence data? And how do we combine these data sets? How do we build a digital infrastructure at a community level? How do we expand to testing for multiple respiratory viruses? Particularly with COVID, flu and COVID started to look similar, but they are distinct. So how can we create smart testing approaches that are more agile and faster to multiple respiratory viruses? And how do we bring all of this together through real-time data analytics? What we have experienced is that it is critical to collaborate across domains and expertise. So collaboration between public health, academia, and industry is critical to advancing infectious disease research. None of these stakeholders can do it by themselves because the innovation comes from science, from research, from digital methods. And we have to learn how to scale infectious disease research. We communicate and work with public health departments and researchers across the country, and that's one thing we hear repeatedly, that we need to get better at acquiring data as well as sharing data and creating large scale to be able to achieve impact to society at a much rapid pace. What we observed during COVID research and infectious disease research in general is that we've been really slow as a nation and as a society to adopt digital first methods. And we believe that's what stands in the way of effective public health response to infectious diseases. One of the studies of the NIH found that if we had used digital plus diagnostics, we could have found 8 more people as carriers of undetected infections because we didn't really increase the accuracy of testing. And also moving towards precision testing. How do we create a low cost, convenient, and scalable approach to testing? As you can see from the images on the right, we all have experienced this, and we don't want to be doing this in the future. So, how can we make it convenient and at home testing a lot easier and more accurate? This is a approach for achieving precision testing method. So this is an integrated data first, AI powered, lots of buzzwords here. But this is one of the initiatives that was undertaken by the National Institutes of Health in the United States, funded through RADx Tech initiative to create next generation technology, digital first approach to combining symptom screening through a mobile device and combining that with the results of a at-home test to achieve higher accuracy and sharing of data in real time to help inform public health response and contact tracing. So an integrated approach is the way to go and more data-driven approach. Another program that has very effectively used the data first approach for digital data collection is the NIH All of Us research program. These are some of the numbers from the NIH All of Us research program that have all been enrolled through a nationwide adoption of a digital platform, number of 620 plus thousand participants, and 23 plus million engagement, and combining that with wearable data and EHR data and genomics data. A whole person is a lot more than surveys. Infectious disease research has primarily relied on survey methods, and they have been very effective, but public health research now needs to build larger data sets that go beyond just surveys. And my colleagues today are going to be talking about that. They are leading these data collection methods for infectious disease. And also, how do we share this data that would come from genomics, environment, lifestyle behaviors, and combine that with community level prevalence data? Because that's what talks about how is the infectious disease spreading at a community level. So with that, let me introduce the two speakers, Dr. Denis Nash and Dr. Inan, and I will now hand it over to Dr. Nash, who would talk about web-based studies to inform infectious disease research. So back to you, Dr. Nash.
Thanks very much, PJ. I'm an epidemiologist, and we are at our Institute for Implementation Science in New York City at the City University of New York. A lot of our work is on observational cohorts historically for a variety of different diseases, and increasingly our work is moving to online internet-based studies to recruit entire cohorts and follow them forward in time without any interactions directly with the study team other than over digital platforms. And so that's what I'm going to talk about. Many important population health research questions extend beyond the healthcare setting and into the community. And these studies need to be community-based, but community-based studies can also be challenging to do at a large scale and in multiple locations at once. So for this reason, internet-based studies are an important way forward. And they allow rapid recruitment because they allow rapid recruitment of large, diverse participant populations, and they can leverage multimodal data collection from phone-based and web-based questionnaires to a wealth of at-home self-collected specimens to capturing data from wearable devices. So what are some of the reasons why it's important in public health, especially in public health research, to conduct recruitment outside of the clinical setting? For one, many people, especially younger people and people without health insurance in the US, may not access healthcare at all in a given year. Such people are different in many ways, important ways with regard to their risk of health outcomes, and excluding them limits the generalizability of public health research in problematic ways. So community-based recruitment extends participation to those who don't have good access to the healthcare system. And also, especially important for public health research, is that its focus tends to be often on prevention, which means that we need to include people who are not sick or not seeking care because of a particular health concern or a chronic condition. And in addition to facilitating larger scale studies, doing public health research over the internet can feel less intrusive to the participants and can facilitate research participation over longer periods of follow-up. Internet-based studies help public health research increase both relevance and rigor. And I like this slide with the 4 Ps for implementation science research, because it helps remind us that it's not about rigor alone or relevance alone. Both are really important for pragmatic and impactful public health research. The graph shows methodologic rigor on the y-axis, very important for science, and relevance to real-world practice on the x-axis, very important for public health research and implementation science research. So obviously, those studies that are neither rigorous nor relevant are simply puerile. But we need to have, we can also have pedantic studies that are highly rigorous but not necessarily generalizable to real-world settings. And similarly, we can have populist studies that are are addressing really highly relevant topics in real world settings, but without much methodologic rigor. But clearly we in public health, where we want to be is in this pragmatic space here with the right balance of relevance and rigor. So to illustrate how our team is conducting this kind of research, I wanted to present an example of a fully online longitudinal cohort study that we launched in March of 2020 called the Chasing COVID Cohort Study. So the Chasing COVID Cohort Study is a community-based national prospective cohort study that we launched during the upswing of the US COVID-19 pandemic. The key objectives were to estimate and evaluate the determinants of SARS-CoV-2 incidence, infection, disease, hospitalizations, and deaths. We also wanted to assess the impact of the pandemic on psychosocial and economic outcomes, and finally, assess the impact of pandemic mitigation strategies on a variety of outcomes, not just those related to COVID. Any adult age 18 or over who resided in the US or a US territory was eligible for inclusion in the cohort, regardless of whether or not they ever had COVID. And recruitment was via referral, via Qualtrics panel, and via ads placed on social media sites like Facebook, Instagram, and Scruff. Very rapidly, we were able to screen about 11,000 people for eligibility, and we required additional steps that included demonstrating engagement in longitudinal follow-up and specimen collection, which ultimately resulted in enrollment of about 6,700 people within 4 months, and most of them had also provided a self-collected baseline dried blood spot specimen. I should also note here that we incentivize participants to complete interviews and specimen collections with incentives ranging from $15 to $30, depending on the activity. And all of these details and others are included in our cohort profile paper cited here. This was the geographic distribution of the cohort looks like. Participants came from all 50 US states, the District of Columbia, Puerto Rico, and Guam. They were geographically and sociodemographically diverse. And while we didn't actively recruit essential workers, we ended up with about 19% of participants in this really important epidemiologic group. And this slide shows the dried blood spot specimen collection kit that was mailed to participants. They received a kit like this at home after they provided us their mailing address with details, including a QR code that would bring them to a video to show them how to go about collecting the specimen. And here we're showing an example of a dried blood spot card that, excuse me, a participant completed. And they just put this back into a bag with a desiccant and in a self-addressed return envelope that's with postage paid, and they just drop it in a postal service receptacle to have it go directly to our lab. And when the lab received these specimens from participants, they were then used for serologic testing, and we did 2 different serologic tests on these specimens, and then banked the specimens that were remaining at minus 80 degrees C. This slide shows the design of the study, including the frequency of interview assessments and specimen collection. As I mentioned, we launched in late March of 2020, and by mid-May to June of 2020 had recruited nearly 7,000 participants, and most of them had provided a baseline dried blood spot specimen. So recruitment was very fast, with the overwhelming majority of our participants still seronegative by the time they enrolled in the cohort. So despite this research happening during a pandemic, we have had excellent retention to date, with 80% of our cohort retained at 30 months after recruitment. And this slide just gives you a sense of the cohort characteristics at baseline. And as I mentioned, this kind of gets at engagement over time. This is the total number of people who were enrolled in the cohort here. And then these turquoise bars show the number of participants that provided a specimen, and these other bars, these lighter blue colored bars, shows the proportion of participants, or the numbers that were completing interviews over time over the web. And this is where we get 80% of the cohort is engaged in some kind of study activity well into longitudinal follow-up. And about 72% of participants that originally enrolled are completing every single interview at this later stage of the study. We thought that is pretty good engagement, especially during a public health emergency. And I just want to highlight an analysis that we published in Clinical Infectious Diseases as an example of how we leverage the epidemiologic information that we collected in combination with the specimens. After we had 2 dried blood spot specimens, we completed an analysis of about 3,400 people who were seronegative on the first specimen, who also had a second specimen available collected at a later time point, so that we could look at SARS-CoV-2 seroconversion and related risk factors. So among these 3,422 seronegative participants, we observed 161 seroconversions over 1,600 person years of follow-up, for an estimated incidence rate of about 9.8 per 100 person years, or about 10% per year seroconversion risk. And you can see here how the sero incidence rate varied by both age and gender. Of course, this is very unusual information at that time in the pandemic, because it's prospectively collected, it's community-based, and it's combined with substantial amount of epidemiologic and sociodemographic data that's not really found in electronic health records or typical medical research studies. And so, for example of that, in this analysis, which was prior to vaccine availability, we really wanted to assess the extent to which social distancing, both with people participants did not know, as well as those that they did know, to what extent is this associated with the risk of seroconversion, even after controlling for other differences between participants. And we found that compared with never social distancing, doing so always or sometimes was associated with substantially lower seroconversion risk. And we also found that using the substantial amount of epidemiologic information in our cohort, we assessed the extent to which different risk factors like household size, or having children in the household, having direct exposure to a confirmed case, attending large gathering, grocery shopping without a mask, all kinds of risk factors that we talked about a lot as potentially important. We were able to examine and quantify their seroconversion risk in our study, both individually and shown here as a composite risk factor that we compiled using LASSO. And so here we can see the additive effects of multiple risk factors on seroincidence during the pre-vaccine phase of the pandemic. So higher risk groups had nearly 4 times the risk of seroconversion compared to those that were in the lower risk category, and those with medium risk were, in between. We're able to do this work in the Chasing COVID cohort because of a lot of important pioneering work in online studies in the field of HIV prevention, led by specifically Professor Christian Grove on our team at the University of New York. These studies that he led focused on enrolling sexual minority men into longitudinal follow-up with home-based HIV serologic testing. This pioneering work enabled us to be very successful with 2 NIH RFAs under the LIGHT program of NIAID, the limited interaction targeted epidemiology to advance HIV prevention. And they solicited applications that were intended to use innovative technology to conduct epidemiologic studies of large cohorts of US populations at high risk for HIV acquisition. And we were required to use the outcome of HIV seroconversion. Importantly, this HIV prevention work needed to be community-based, as many people at high risk for HIV have very little to no healthcare access. And to be adequately powered, we also needed to enroll large numbers of sexual minority men, including men of color who are at highest risk for HIV in the US. And this study helped to shed shed light on an important challenge around access to HIV pre-exposure prophylaxis, or PrEP. In the PrEP era, our questions were, what are the barriers and enablers to PrEP uptake in those at very high risk to for HIV acquisition? I'll tell you briefly about the first large study by our team under the LIGHT initiative, led by Christian Grove, which was the Together 5000 study. The T5K study was an implementation science cohort study that enrolled US-based racially diverse samples of HIV-negative men, trans women who specifically were not on pre-exposure prophylaxis into our cohort to inform the design and implementation of scale up of HIV prevention programs that could effectively reach this at-risk population. And we used internet-based strategies to enroll this cohort of HIV-negative men, largely via sexual networking apps. And so this slide with some data from our cohort profile paper highlights the scale, the rapid recruitment, and very specific recruitment around HIV risk that we were able to conduct with specimen collection at baseline and during longitudinal follow-up. In this study, participants submitted a self-collected buccal swab, which was used for HIV serologic testing. And over the course of our 48-month study, only about 30% of participants ended up initiating PrEP, and between 6 and 10% of participants seroconverted. So this produced valuable data around the gaps between HIV PrEP uptake and HIV seroconversion. And in our most recent LIGHT study, which is called Amethyst, we've been successful at obtaining self-collected rectal swabs from participants for testing inflammatory markers. So in conclusion, I'll wrap up here to say that on our team, we've recruited thousands of participants into cohort studies using internet-based approaches. We've learned that these approaches to cohort studies can offer some key advantages over traditional study designs, especially for public health and implementation science research, including during public health emergencies. Some strengths of these approaches include that they can be community-based and inclusive. They can recruit rapidly for baseline and follow-up data collection. They can be highly scalable. We don't require study centers that are geographically located in fixed places to recruit. They can recruit anywhere. It's participant friendly, and we think that leads to better retention, less intrusiveness around questions that are perhaps difficult to both ask and answer, and that reduces interviewer bias since we have no interviewers. It's cheaper, and it can collect a wide range of self-collected specimens, which I alluded to a little bit in our own research. And you can even get to the point of administering interventions in these kinds of studies, as long as they can be deployed remotely or digitally. But of course, there are some key limitations. They're susceptible to fraud, like internet bots, but we also know that bots can't submit specimens. So when you do these kinds of studies with specimen collections, it helps to ensure that you're dealing with real people, but there are other ways to limit the participation of bots in studies like ours. We can't, of course, include a physical exam or other clinical assessments or even laboratory tests that require phlebotomy and a cold chain. So that's a limitation, and it can be challenging to assure representativeness, but this is a limitation that's really true of most longitudinal studies. And some interventions can't be administered remotely, of course, clinical exams and radiologic studies, new treatments, drugs, and vaccines. But the approach is being used by our team and increasingly other teams around the world. And together we've learned a great deal about how to optimize the design of these studies to achieve each of our studies' research goals while maximizing both relevance and rigor. And before I stop, I just want to quickly acknowledge the cohort participants in the C3 study and our study teams, as well as those of the Together 5000 team. Thanks very much. Back to you, PJ.
Thank you, Dr. Nash, for sharing about your team's pioneering work, particularly in the field of HIV and the infectious disease, and how the model of community-based public health research and implementation, one is able to create and add a digital component to that for much broader and rapid expansion of that epidemiological study through the internet. And this is going to form a data infrastructure that can help us respond rapidly to infectious diseases in the future, and the learning and the knowledge that is being created. Now we will transition to Dr. Enon, who will share his research that utilizes wearable devices, mobile phones, and can help detect and monitor infectious disease. His work comes from the cardio field of cardio and how they have adapted to these additional methods and incorporated more data collection, novel data collection from new sources. So handing it to you, Dr. Enon, take it away.
Thank you, Dr. Nash, for the excellent talk. So I'd like to just start with a couple of disclosures. So I do have some involvement on the industry side as well. I'm a co-founder of the company CardioSense that's trying to commercialize our wearable patch technology that I'll talk about actually during this presentation. So it's relevant to mention that. And we also have some other industry engagements with the lab that I wanted to mention. So I think that this, and we've been thinking about this problem for quite some time, exactly as PJ had mentioned before, this concept of being able to collect at higher degrees of frequency wearable data from persons at home to try to detect exacerbations or changes in physiology that might be indicative or predictive of things that are going on has been something that our lab has been very excited about and has been working on for quite some time now. So the concept that, the only data collection that happens is in the clinical setting, exactly as Dr. Nash was mentioning as well, is kind of not something that can work well for many of these sorts of problems where things are really changing at a much higher frequency than the once per year or once per couple of years or however often you're actually going to a doctor's office. So the important thing is to understand what needs to be measured to be able to have the right level of predictive window where changes can be made to avoid these sorts of events. So what we've worked on quite a bit is trying to incorporate greater than just heart rate, respiration rate, and some of the basic vitals into wearable technology. And so I'll talk about some of the things that we've done along these lines. What I have pictured here is kind of just a timeline that we've thought about a lot in the case of patients with heart failure, where what we're interested in is gathering information on the right types of variables while the person is at home, moving around freely, so that we can detect as early as possible hemodynamic congestion that can lead to exacerbations and hospitalizations. So there are, of course, many wearable devices out there now. So many of which, of course, started as more consumer gadgets and now are moving more into the medical device space, where they have actually done in some of these wearable devices the right sorts of validation studies where you can really trust the data and where it's been linked to health outcomes. And it's quite an exciting field actually to be in right now. Um, and it's something that I think will really play a major role in infectious diseases research, hopefully over the coming years. So one of the things we've worked on is taking a wearable patch. So there are many wearable patches out there that are more like Holter monitors that effectively have completely changed the landscape of Holter monitoring, from having a belt-worn device that has wires coming all over the chest to different electrode placements, to instead having these fairly compact, easy to use patches that the person can put on, or that a care provider can put on with ECG electrodes, allowing the device to be mounted to the skin on the chest. So what we've done is we've actually built up a patch with many different iterations, and this was in collaboration with Northwestern University as well as UCSF's cardiologists, especially Liviu Klein and Dr. Mazied Ahmadi, who have been really instrumental to the research. And what we've done is we have taken this patch and we have incorporated not just electrocardiogram sensing, but also photoplethysmogram and seismocardiogram sensing on the same device. So you have electrical and mechanical aspects of cardiac function, and then with multi-wavelength PPG, you also have the peripheral pulse that can be detected on the patch. And this is something that we've studied heavily at this point in patients with heart failure, with more than 100 to 200 patients using this device in various studies, previous iterations of the device as well, and especially looking into hemodynamic changes in the context of exercise. My lab has also developed wearable watch-based sensors to detect these same signals where the person will place the watch against the chest. So similar to the type of data that you can get in more consumer grade and commercially available watches, but also incorporating this cardiomechanical sensing that our lab has specialized in through the seismocardiogram signal, which is kind of like a acceleration of the chest wall in response to the heartbeat, which is an interesting signal that gets at the mechanical aspects of heart function. And so in the same spirit of broadening the information available from wearables to cover not just cardiac, but also cardiopulmonary variables, our lab had actually worked on this device, and this was in collaboration with Emory University with Dr. David Wright and Rishi Kamalaswaran from Biomedical Informatics. And we had worked on this device that we have now tested in about 10 or 15 patients who were hospitalized at Grady in the emergency department. And we've recorded measurements from them of lung sounds from various places on the chest and back, as well as impedance pneumography through a single device that then allows these basically to be recorded in a way that both signals can be analyzed in the context of each other. And I guess the higher level point that I'll make here is it's been important for our lab, and I think that for this area it's important, that there are multiple measurements that are complementary, that are taken with the same hardware, so that the algorithms for analyzing these signals can understand each signal in the context of the other. Sometimes that helps you with addressing noise and reliability issues, but sometimes also these different pieces of information are additive in their value in terms of what you're trying to sense. So with this hardware, we really wanted the sounds to be able to localize any sort of crackles or other sorts of fluid-related issues in the lungs. And we wanted the bioimpedance to give us a more holistic picture of both the changes in tidal volume, respiration rate, respiratory intervals, but also potentially detection of fluid in the chest cavity or lungs associated with edema. So that kind of leads me into this point that, it's important to extract key contextual information, but also health parameters from wearables. And the space is changing so fast that, it's difficult really to keep track of everything that's going on, but it's actually a very exciting time because of that. So our lab has done some interesting work and others have as well, in the framework of not only analyzing the physiological data, but also trying to understand the activity context and quantify activity context from persons moving freely in their normal daily activities of living. And for this, actually, what's been very important has been to be able to fuse different data sets together through transfer learning and domain adaptation approaches. So this was an approach that we used recently to be able to fuse two different data sets, two different domains of data collection, one that were collected from another group from University of Michigan that was available online, and one that was collected from our group here locally at Georgia Tech. And we demonstrated that, in this setting where you have very little labels, weakly labeled data that's sort of semi-supervised in some ways, or maybe weakly supervised at best, that we were able to achieve activity classification with higher accuracy by this sort of transfer learning approach, or I should say domain adaptation approach. And we also more recently published a paper where we took advantage of the structure actually of the activities to be able to train the model. And I think that in all of these, what's important is the fact that the activity is serving as a context for being able to detect the physiological changes. So measuring changes in hemodynamics or cardiopulmonary variables on their own is very interesting, but if you detect that the person is walking upstairs at a certain pace and you know what their, say, estimated metabolic rate is for that task, and then if you examine the physiological changes in response to that, that could be a much more powerful early indicator of something going on. So that's where we're trying to head with this work. So you can see that this system that I mentioned, the multimodal system for tracking pulmonary fluid status, lung sounds, as well as tidal volume changes in hospitalized patients, you can see that there's a lot going on with this. There's many sensors still. This is obviously still early stage research. But here we're trying to understand what the most interesting and important information is so that we can then miniaturize the system later to only the sensors that are really providing the greatest value. So one of the things you'll see here that's interesting is, this patient from which we were recording data had inspiratory crackles, and you can see that during inspiration is when you start seeing the greatest amount of acoustic output from one of the lung sounds microphones. And we found a lot of interesting things from these approaches. The other thing I'll mention is one of the reasons why I think it's very important that we not only use consumer grade wearables, but actually we really think about the validation of the information from each wearable device very carefully, is that there's a lot that has to go on in terms of the design of the devices to make sure that the data captured is actually of sufficient reliability and robustness for the future algorithms that are developed. So if you look on the bottom left of this slide, the amount of work that actually went into building the casing for the quote unquote microphones, really contact accelerometers that were picking up the lung sounds, was quite extensive to make sure that the sounds were not being altered by the hardware itself, and to make sure that we minimize the artifacts from the body motion on top of the microphones. We've done a lot of work also in hemodynamic monitoring that I'm not going to get into in that much detail, but quite a bit of work on trying to estimate trending in blood pressure with wearable devices, as well as trending in stroke volume that we've done in collaboration with clinicians. One of the things that I think is very important is oxygen uptake and peripheral O2 sat measurements with these sorts of wearables. And again, every time we get into these sorts of problems, we realize, we're humbled by how difficult things are actually. So there's many devices out there that will give you estimates of VO2 or energy expenditure. And it turns out actually that the, third-party groups that have done evaluations of these devices find that there's a lot of noise in those measurements, so much so that it's almost, you could almost get away with predicting the mean for that activity and do a better job than with the wearable. So we really have to be careful about, the validation, the gold standard that we use to compare against, and the physiological underpinnings. So with our group, when we find these relationships between, VO2, let's say actual and predicted with our device, we really look into which variables were behind that, and does it make sense from a theoretical standpoint that those variables would provide that information. Same thing for respiratory parameters like respiratory rate and tidal volume. I think the pandemic really alerted us to the fact that while we would love to have even better tools for cardiovascular sensing, we're even further behind in terms of high quality wearable devices that we can trust that provide information on respiratory rate, respiratory timings, and potentially tidal volume. So I think that more work has to be done there, especially since many of these sorts of respiratory viruses, of course, they have an impact on breathing parameters and effort of breathing. And so it'd be important to expand what we can do in that area. This is just another slide showing the VO2 estimation with our parameters. So I think this is the last sort of content slide, and I want to mention, a lot of what we've done here in terms of being able to broaden what we can measure in terms of cardiopulmonary parameters from wearables really started with the work that we've done in heart failure. And this work that we did was an important advancement in wearable sensing in patients with heart failure that ended up leading to CardioSense, the company that we founded, receiving breakthrough designation from the FDA. And the main concept really with this particular study was that rather than looking at the signals just at rest, we used the 6-minute walk test as a prescribed activity from which we wanted to measure the changes in our signals compared to their resting values. So essentially there was a fixed dose of activity, and we measured the changes in the parameters in response to that dose of activity. And that ended up being much more sensitive than the signals measured at rest themselves. And we were able to differentiate between decompensated and compensated heart failure patients just from their mechanical aspects of heart function measured through the wearable accelerometer and how that changed with this prescribed activity. And so with that, I want to, of course, also thank the amazing PhD students that I get to work with and research engineers I get to work with on a daily basis who really make this work happen, as well as, of course, the sponsors. We have quite a bit of sponsorship from NIH, of course, but also from DoD, DARPA, and ONR that allow us to bring higher risk technologies forward towards these applications.
Thank you, Dr. Inan, for sharing your pioneering work in the areas of using mobile devices and wearable sensors and looking for signals that can help infectious disease research move left and become more preventative, more predictive. I also want to talk a little bit about how do we apply the findings from our speakers and those learnings into public health research for infectious diseases. We talked earlier about that it takes diverse stakeholders to come together to really create advances and novel methods for infectious disease research. As an example of that, I wanted to show here a technical architecture of a mobile health platform that Vibrant has been working with the NIH as well as the research community at large. As many of you know, that data integrations are hard, they're difficult, and also it's hard to scale those data integrations. Dr. Inan was talking about surveys and doing sample collection through community-based kits. Dr. Inan was talking about data from wearable devices, mobile devices, and to be able to harmonize that data. So all of these disparate sources of data require a secure and centralized locations for management of that data. And that's what this picture on the screen is talking about, is how that approach can result in a more streamlined and cost-effective way for infectious disease research. So we've been addressing these different bullets that we talked about earlier in the presentation around smart testing through diagnostic and by combining software with hardware, testing hardware in a kit. We spoke about comprehensive data collection. Dr. Nash and Dr. Enan talked about different approaches to data collection. Also, we talked about detection using some of the AI approaches that the NIH RADx program promoted and funded. All of that then starts to form a digital infrastructure for testing for multiple respiratory viruses as new infections and new pandemics come and go. We look for collaborations, and we think we can help. So we invite collaboration discussion and how we as researchers can incorporate genomics, environment, lifestyles, and behaviors in a community setting and combine those data sources for predicting and preventing infectious diseases. So with that, thank you very much for your time today. And we are on to Q&A.
Okay, thank you to you all for that very comprehensive presentation. It is now time for the question and answer session. To ask a question, please type it in where it says type your questions here and then press submit. Okay, so to get us started for today, I wanted to open with this. What concerns do internet research-based studies bring up when reviewing studies with novel data collection methods? Perhaps if I can ask Dr. Nash to begin.
Thanks very much, Sarah. Yeah, so I think that for that one, I might just cite an example of how it's really different when we're collecting data over the internet and on a large scale. So in a traditional study, when you're administering data collection, for example, in person with the participant in front of an interviewer or a nurse, data collection happens at a pace that is sort of commensurate with however many staff you have. You can ask questions and you can gather information, and if something goes wrong, if the participant becomes sick or upset, there's a possibility to intervene and get them whatever services it is they may need. In our internet-based research, for example, when we send out a wave of data collection, for example, a 6-month follow-up interview, about 4,000 people might complete that on one day, and maybe another 2,000 will complete it the next day, and that makes it hard for us to ask certain questions. And this came up during the COVID-19 pandemic work that we did. We wanted to ask about suicidal ideation of our participants because this is depression under lockdown and the stresses of the pandemic and many other things that were happening. We sensed through our other measures were really wearing on people. And so, but our IRB doesn't like the idea of asking those kinds of questions when, if a participant were to endorse suicidal ideation, we could not step in and then provide that participant quickly with the resources and connection they need. And it's impossible to do at that kind of scale. And in a national study, the people who do it would need to be licensed in the specific areas where the participant lived. So it was really infeasible for us to ask certain questions because of valid concerns from our IRB about whether we can ensure the safety of our participants in some situations. Okay. That's one big challenge.
Yeah, thank you very much. Dr. Enan, I don't know if you had anything you'd like to add to that.
No, I think it's an excellent point. I think that the way that he phrased it is exactly right. I think that makes a lot of sense.
Okay, perfect. Then I will move on to our next question. The question is, how adaptable do you think these novel data collection methods are in resource-limited settings or developing countries?
Well, I'm happy to take a stab
Please.
at that. Increasingly, as everyone knows, people do have access to data-powered cell phone devices and and tablets and things like that. And so that makes it much more feasible. That's really all you need for the kinds of studies we do, is some kind of internet-enabled device where we can send an email or send a text or direct people to a link. So I think it's increasingly possible to deploy in a range of settings. However, regardless of where you are, there are always people that are less well connected to the internet, maybe less literate and less able to participate in a study that requires, reading a questionnaire. And there are increasingly approaches that can be used to include participants that are in these situations. And this is a really important but evolving area.
Thank you so much. And PJ, I wonder if you had any further comment on that.
Yeah, thanks, Sarah. There's a lot of work done working with the National Institutes of Health and nationwide around diversity, equity, and inclusion. So the NIH All of Us research program, as an example, out of over 700,000 participants, 80% of them are classified as diverse. It's a very broad definition of diversity across race, gender, ethnicity, socioeconomic status, rural versus urban, literacy levels, etc. So I think if we start with the least common denominator, which is what research has not traditionally done, but if we start with that as the goal and say, look, we are going to help achieve equity, then the methods can be adapted. Certainly, Dr. Nash talked about less resourced locations and countries and people, but there are also expansion of broadband, expansion of wireless network that are becoming more and more capable across much broader geographic and socioeconomic regions of the country and the world. So I always encourage to say, let's not wait for, let's not perfect be the enemy of good. There is plenty here to help a lot of people. Let's start thinking about implementation and not keep waiting.
Thank you very much. Our next question then is whether or not any of these methods or devices have been validated in any LMICs. If so, where? And can you further point us in the right direction?
Do you want me to maybe take this one? Yeah.
Please.
So with our devices in particular, we have not validated them in any LMICs so far. We have, however, partnered with medically underserved communities and especially nonprofit organizations that work with those communities in the US. And the main reason for that is, and I think there's sort of a increasing level of challenge and maybe also potential for making impact as we go from, as we broaden to underserved communities in the US and then from there to also LMICs. I think that there are some challenges that are shared, but then some that are just entirely more difficult when we get to LMICs, to be realistic. So within even the US, though, and medically underserved communities, I think what we found is that first of all, involving the right partners in our research early on who understand communities that can really benefit from these sorts of technologies, where currently they're being, unfortunately, they're dealing with many health disparities and already kind of require, of course, efforts to be able to achieve equity, as PJ had mentioned. So I think involving partners early on in this sort of work is really important. We would love to partner with groups that are working with LMICs that think that some of the sensing technologies we're working on may have impact there. I think it would be a great next step for sure. For us, it's always about making sure that what we measure is really what we think it is first, and then trying to broaden who can really benefit from it. It takes a long time.
It sure does. Thank you so much. And I think we have time for just one more question, and that is one on regulatory issues. So the question is, how can regulatory issues be navigated during studies with novel technology? Perhaps I can hand this over to the two of you to comment, and then we will need to close. Your thoughts?
I mean, from my standpoint, maybe I could start, with novel devices, there's always a process that has to be followed. And usually it involves both the local institutional review board, as well as thinking about FDA and what's required from the US, Food and Drug Administration, what's required from that agency's standpoint. And so we follow those guidelines very carefully, and they're there for a reason. And so it's important to sort of stay within those, I think. But I don't think there's, for us, because wearables are non-invasive devices and they're almost always, non-significant risk devices as determined by local IRBs, it ends up being a pretty reasonable process to, fall within that.
Okay, and Dr. Nash, if I can take your thoughts.
Sure. And an example I'm thinking of for us is we're using assays that are more in the research context and not necessarily, CLIA approved or even FDA approved. They're under emergency use authorization by our federal government. And so that needs to be clearly communicated to participants, and it becomes a challenge to return results of tests. We do it, but we contextualize it very carefully, and our IRB is very concerned with this too. That it does not necessarily constitute a diagnostic test, and that they should seek testing with a healthcare provider to confirm anything that we tell them that we've observed.
Okay, wonderful. Thank you so much. And that is where we are going to have to finish for today. We are aware that there are a number of questions that we didn't manage to get to, and we will get back to you offline after this broadcast finishes using the details that you've provided. So I would like to thank Dr. Omar Inan, Dr. Denis Nash, and Pradyuman Jain for being with us today and for answering your questions. I would also like to thank the webcast sponsor, Vibrant Health, and of course, you, the audience, for taking the time to be with us on this webcast today. Remember, you can watch this again at any time on demand at nature.com/webcasts. Thanks for watching, and I hope you'll join us again soon.